So, very good morning to one and all. So, today we'll be taking a case report of tooth infection and insight. So, these are my contents. Coming to the introduction, fractures are one of the major conditions in human teeth that results in pain or tooth loss. However, when a tooth fracture is incomplete, the presentation is more subtle and frequently remains undiagnosed due to its vague signs and symptoms. Tooth infection can be defined as incomplete tooth fracture extending partially through a tooth. According to Ellis, it can be classified as fracture plane of unknown depth and direction passing through the tooth structure and may advance to connect with the pulp or periodontal ligament. It can be identified as three distinct types: those confined to the enamel, those related to cuspal fractures, those are more centrally located involving the pulp. In 1954, Gibbs termed it as cuspal fracture. Million termed it as fractured cusp, and in 1962, Sutton termed it as grease stick fracture. It was called as crack tooth syndrome by Cameron in 1964, whereas Ellis termed it as incomplete tooth fractures in 2001. So, AAE, American Association of Endodontics, further classified it as grace line, fractured cusp, cracked tooth, split tooth, and vertical root fractures. If we check the incident, 2 to 3% of dental patients have tooth infection in the molars and premolars. Patients aged between 30 to 50 years are commonly affected. If we check the predilection, men and women are equally affected. The location of the fracture mostly occurs in the mesiodistal direction. Etiology includes occlusal factors and complex restorative procedures like complex amalgam restoration, amalgam pits, etc. Parafunctional habits like bruxism uh, and other habits like wearing lingual barbels, and during 90-year rotary instrumentation also we can predict crack tooth syndrome. If you check the clinical manifestation, initial stages include hypersensitivity to cold, sweet food, and acidic beverages, discomfort on chewing on certain food consistency, and we'll get the characteristic rebound or relief pain. Whereas in advanced stages, it includes pulpal necrosis and tooth turns asymptomatic, and later stage tender on percussion is present. Symptoms of apical periodontitis also arises. Various diagnostic aids like dye examination, bite test, transillumination, and dental operating microscope can be used. And the treatment plan include first initially we have to assess the tooth. If in case of small peripheral cracks, remove the compromised portion and restore with composite or cast restoration. Whereas in large central cracks with no pulpal involvement, we should stabilize the tooth using orthodontic bands. Whereas if there is pulpal involvement, we have to stabilize the tooth with orthodontic band followed by endodontic treatment. And if the prognosis is hopeless, we can do extraction. According to Clark and Copeland, the prognosis of the cracked tooth can be classified as excellent, good, poor, hopeless. If it's excellent, cuspal fractures within the dentine that angle from the faciopulpal or linguopulpal line angle of a cusp to the cemento-enamel junction or slightly below. It is called as poor, good if the coronal vertical fracture that runs mesiodistally into the dentine but not into the pulp. It is poor if the coronal vertical fracture that runs mesiodistally into the dentine and pulp. It is hopeless if the coronal vertical fracture runs mesiodistally through the pulp and extends into the tooth. Coming to the case report, a 45-year-old male patient reported to our department with chief complaint of pain in his right and left lower back tooth region since 15 days. History of present illness include pain was sharp, intermittent in nature, which increased on chewing hard substances. It was patient's first dental visit, and If you check the medical history, patient is non-diabetic for past 5 years. On clinical examination, the tooth was seemingly intact without clinical evidence of dental caries with respect to 4-7. Generalized attrition was noted. On radiographic examination, no radiographic evidence of dental caries. Widening of periodontal space with respect to 4-7 can be seen. Major diagnostic tests like cold test and heat test EPT were performed, which showed no response, and the tooth was tender on percussion. And our provisional diagnosis was symptomatic affected periodontitis, and the treatment plan was advanced stabilization of the teeth with orthodontic band, followed by root canal therapy and full coverage prosthesis. And our treatment plan was and the treatment rendered was orthodontic band was placed as you see in the diagram, and under rubber dam isolation access cavity preparation was done. Copious irrigation with sodium hypochlorite followed by saline rinse is done. Working length determination was done using root apex locator. Cleaning and shaping was done with the help of neoflex rotary files and master con selection was done. And finally, we obturated the canal. On clinical examination, seemingly intact tooth with clinical evidence of dental caries. Without clinical evidence of dental caries with respect to 3-7 was noted. Then under rubber dam isolation, access cavity preparation was done, and the same like the 4-7 uh, working length examination and the cleaning and shaping was done, and finally we operated the canal. Coming to the discussion, cracks have been regarded as the main roots of pulpal infection in traumatized teeth with apparently intact crown. Ritchie et al. Observed that teeth with incomplete fractures had often been weakened by respiratory materials, which did not offer protection from the forces of occlusion. But it is interestingly to note that high percentage of teeth with fracture was having no restoration. It is also observed that tooth fracture will occur sooner in mandibular molars than in maxillary molars, which are protected by transverse ridges, in addition to marginal ridges. The act of chewing food is also implicated as an predisposing factor, like repeated occlusal overload due to oral habits or accidental biting on hard things, which may lead to tooth infraction or vertical root fractures. As per histobiological observation, the tooth cracks, regardless of their location, direction, and extent, were always colonized by bacterial biofilm as they are written deep. Cracks are bathed by saliva and are difficult or impossible to be cleaned during routine oral hygiene. It is well recognized that when dentine is exposed, the pulp is put at risk of infection as a consequence of permeability of dentine dictated by its tubular structure. Patient has symptoms ranging from occlusal discomfort to severe prolonged pain. According to Brainstorm, the characteristic relief or rebound pain occurs due to sudden movement of dentinal fluid when fractured portion move independently, activating air ducta fibers and creating rapid acute pain response. Prevalence study have found that mandibular second molars were the most likely to have a fracture. This occurrence were nearly twice as great as that of maxillary molars, the next most commonly fractured teeth. The greater force present in the second molar region as compared to the first molar as per the principles of Leo is undoubtedly another explanation for the increased number of fracture noted in the mandibular second molar. So, if you check the differential diagnosis for cracked tooth syndrome, acute periodontal disease, reversible pulpitis, dentinal hypersensitivity, galvanic pain, fractured restoration, areas of hypoocclusion. Management of the present case consisted of stabilization of the fractured tooth with orthodontic pad. Under rubber dam isolation, the access cavity was done, the canal were located, and crack was visualized, followed by cleaning and shaping, and obturation was complete. Adhesive post-endodontic restoration using GAC the patient is advised to undergo full coverage restoration. So finally, we would like to conclude the prevention and early recognition of cracked tooth syndrome is essential for avoiding more injury and preventing the progression of cracks into the pulp. Simple tools such as trans illumination, bite test, macro photographs, and isolation with a rubber band are useful for locating incomplete fractures. And the take home message is during your clinical practice, if you come across a seemingly intact tooth with no clinical or radiographic evidence of caries or particle pathosis, we can always suspect a cracked tooth syndrome. So these are my references. Thank you.